Hello everyone and welcome to today's webinar. The topic of today's webinar is cancer and its care. My name is Leslie Pugh and I'm a Professional Development Officer at APNA, the Australian Primary Healthcare Nurse Association. This initiative is part of the Chronic Disease Management and Healthy Ageing program, which has been funded by the Department of Health, and this webinar is being brought to you by APNA, the Australian Primary Healthcare Nurse Association. This webinar is live and interactive. Please use the blue raised hand icon at the top of your screen to submit questions at any time during the webinar. Questions will be answered at the end of the webinar, and additional questions that don't get answered will be followed up after the webinar. If you experience any audio difficulty during the webinar, please dial the 1800 support number listed in the chat box. An evaluation will also be sent to you straight after the webinar, and it would be great if you could take the time just to fill that in for us. You can download any resources discussed at the end of the webinar or during the webinar by clicking on the blue downward arrow at the top right corner of your screen. So thank you for coming and welcome. And I'll just introduce each of our panel here today. So Meg, she is a cancer survivor, and thank you for being with us today.
Thank you.
We have Tracy Murphy, the coursework coordinator of primary health care. Thank you for coming in. Jessica, who is a clinical nurse educator for Western Health. Thank you. And Catherine Lade, head of cancer information and support services. Welcome. And then we have Nicole Kinane, project manager of Australian Cancer Survivorship Centre, a Richard Pratt legacy at the Peter MacCallum Cancer Centre. Thank you so much for coming in and sharing in this webinar with us. So I guess we might just get going with you, Meg, if that's okay. If you could just tell us about your journey and your experience and interaction with primary health care during your cancer diagnosis and treatment.
Sure. At the outset, let me say that I love words and I write down what I want to say because the words that I use are important to me. So bear with me and I will read to you what I want to say today. A 25-year cancer journey, 3 diagnoses of Hodgkin's lymphoma, each with increasing severity, followed by a breast cancer diagnosis requiring double mastectomy and reconstruction, and more recently something anecdotally known as breast implant illness, prompting the removal and replacement of my implants and their scar tissue capsules. All the while, the words of well-meaning friends from that first time echoing in my ears. You're so lucky that it's Hodgkin's. That's the best cancer to have. No chemo. That's the worst. I've taken the experience of those diagnoses, the treatments, the chemicals with unpronounceable names, the caring staff encountered, the emotion, the support of my wonderful family and friends, and distilled them into a passionate journey to assist, to offer hope, to inform, and help others learn about cancer and survivorship. 25 years ago, I nervously ventured into my local GP's rooms, indicating a lump I'd found on my neck. From that instant, a giant capital C was emblazoned onto my forehead, and an uninvited and generally uninformed roller coaster ride began. No indication of what might be found following a hastily arranged needle biopsy or subsequent follow-up to a haematologist. There was very little support available, no websites offering information, no linking with other patients, no support groups, no one to talk to apart from the doctors, nurses and technicians. Supportive care screening, needs assessments or care plans unheard of. I created my own spreadsheet, which now runs to 5 pages, to inform each new doctor of what had gone before. There were, hastily mentioned, a list of side effects and possible late effects of treatment, and just my luck, I worked my way steadily through most of them. One so rare, it had my oncologist of the time scrambling for a textbook with excitement. Diagnoses, treatments, hospitalisations for side effects, surveillance and testing. Where did primary care fit into all of this? Through my GP, certainly, but where, if they'd been available to me, would primary healthcare nurses have come into the picture? My experience was in the absence. The closest I came was my breast care nurse. I can only tell you how I feel others are and can be assisted by what I believe I missed out on over those years. A first point of call for any health concerns, my GP has always been the go-to for my health, myself and my family. For a concern which subsequently becomes a cancer diagnosis, that visit leads to testing and subsequently a specialist referral. The metaphor of the fairground could be continued here. Now you enter the funhouse, the house of mirrors. Nothing is as it was before, and nothing as it seems. The floor moves and might fall away beneath your feet. The reflection you see is not one you recognise. It's an overwhelming time, one of heightened emotion and fear. Before that first referral, support is needed which can be provided in the primary healthcare setting. Lots of questions need answers. The primary healthcare practitioner and primary healthcare nurses have the ability to assist and guide their patient with information and support. Referral to the Cancer Council 13 11 20 helpline as a starting point. Has there been a discussion around public versus private? What are the costs involved? Will private healthcare cover the costs of all tests if they're not bulk billed? Information about Medicare-funded healthcare plans in your local area. Referrals to social workers, psychologists, exercise physiologists, dietitians, physio and occupational therapists, among others. How to navigate the system when English is not your first language. Perhaps not quite the moment for healthy lifestyle advice. There'll be time for that further down the track, although stressing the benefits of exercise during treatment would be of benefit. Once the roller coaster of testing and treatment begins, there's not much time for primary health care. Specialists, oncology nurses and technicians fill your days. An unexpected fever, ache or pain is reported to them rather than to your GP. Reports outlining treatment protocols and test results are slow to make their way back to the primary healthcare setting. GPs are rarely included in multidisciplinary meetings. Many of your patients will be regulars. Coughs, colds, breaks, sprains, allergies, comorbid conditions which are dealt with on an ongoing basis. They need to be encouraged to continue attendance for ongoing treatments, and during the time, conversations can be directed to the kind of assistance you may be able to offer them. One of my biggest complaints around the treatment of cancer is that we, the patients, are seen by our treating teams mostly through the prism of the giant C on our foreheads. This is their focus, to diagnose and treat our cancer. Your focus is much more rounded. You already know us. You treat our coughs and colds, our families. You know much of what is going on in our lives. You have the ability to pick up on those issues and problems and guide us to the supportive care we may require. I heard a definition of recovery which resonated with me. Recovery is the regaining or reclaiming of that which has been lost or taken away. So once our time in the acute setting is over and we begin our new normal lives, our survivorship, we need your help to recover, to regain our strength after treatment, to learn to cope with bodies which may look or function differently, to reclaim confidence when we feel stuck and unsure about returning to work, to help us with our anxiety around checkups and the discovery of side effects, late effects or possible new symptoms, to returning to the system if that's required. Currently, I'm part of a shared care regime between my GP and the late effects clinic at APNA. Over a 25-year cancer journey, apart from those initial tests and biopsies, this is the most active my GP has been in my cancer treatment or my active surveillance. For today's cancer patients and survivors, There are now so many ways that GPs and primary healthcare nurses can be integral to their diagnosis, their treatment, their recovery, their ongoing well-being, their survivorship.
Meg, thank you so much for sharing that journey with us. It's been a harrowing journey, but I think you clearly outlined some of the gaps we have in primary healthcare, particularly when it comes to moving from one stage of the treatment plan to the next. And thank you so much.
Pleasure.
So then I might move over to you, Tracy. If you're thinking about primary healthcare nurses and the role they can play, we've identified some gaps at this stage. So can you just talk us through what you think the role of the primary healthcare nurse could be, including detection, diagnosis, treatment and the support for patients with cancer and survivorship?
Okay, so we've been talking a bit among ourselves. And really there are two poles at the moment where primary care nurses are involved. So you've got the early detection and treatment and screening, and then you've got survivorship at the other end. The bit in the middle, the patients tend to disappear once they've got a diagnosis and we don't see them back, but maybe that is something that could change in the future. So I've been a nurse in primary care since 1990, and most of the time I've spent in preventive health. So vaccination and cervical screening have been my two main roles. And lots of nurses are nurse immunisers and screeners, and they can make a big difference in preventing cancer. So we've got two cancer-preventing vaccines. There's the hepatitis B vaccine, which prevents chronic hepatitis B, which can cause hepatocellular cancer, and the human papillomavirus vaccine, which prevents mainly cervical but also other anogenital cancers. So although hepatitis B vaccine, we've been vaccinating infants since 2000, you'll still have a lot of people in your surgeries who are sort of from 30 and above who won't have had those vaccines. They might be at risk due to occupation, or maybe another high-risk group like men who have sex with men. And it's important for us to identify so that these people can be tested to see that they are negative. If they're negative, they can be vaccinated, and if not, then they can be monitored and treated and prevent that progression to cancer. With HPV vaccine, although the uptake of that has been really good, there are still these pockets of areas of low socioeconomic areas and remote areas where the uptake hasn't been so good. And I was amazed when I was working in a school in Ballarat doing immunisations that girls would come and they would have their slip signed for their Boostrix but not for the HPV. So these are not anti-vaccine families. They're just still a bit suspicious about HPV vaccination. And so as nurses tend to be everywhere, you do have the opportunity to opportunistically catch those girls and offer them vaccination. So we've got free catch-up to under 20s. We also in Victoria have a vulnerable citizens classification, so that people who missed out on the vaccination due to socio-economic reasons can receive that free vaccination at any time if they were due it. It's a fantastic vaccine, and I was just reading today that they're hoping that by 2035 we'll have knocked cervical cancer on the head. So
Amazing.
That's a big role that nurses can, who are working in general practice, can take, is to just to make sure that we get these vaccines to everyone. With hepatitis B, the risk groups, there are people from high-risk countries, which tend to be Asia and sub-Saharan Africa, who may not have been vaccinated and may actually have hepatitis B. And also Aboriginal and Torres Strait Island people have much higher rates of liver cancer, 2.5 times that of other Australians. So by identifying them, not only can you make sure that those people are treated, but you can also vaccinate contacts and make sure that they don't get the disease. At the moment, we've got the QI-PIP, which we don't know that well yet, but you have the opportunity to do 4 quality assurance programs a year. And this could be something, if you've got high rates of people from a particular area, that with your PHN, you could be looking at how you could identify these people and how you could get them vaccinated as one of your quality assurance programs. With cervical screening, nurses in Victoria who are cervical screeners, we've got very good data about the quality of their work. We know that they see more older women, they see more women from the lower socioeconomic status, and they also see more women who are underscreened, so that's generally women who are disabled, Aboriginal Torres Strait Islander women, maybe lesbian women or trans women, and women whose first language isn't English. So it's really important that nurses take that opportunity to learn about cervical screening, and even if you don't want to be a cervical screener, you can inform women about the need to continue screening. There's also the option now of a self-collect if you're more than 2 years overdue. And this is a great test as well for women who've had cancer treatment, and putting a speculum in it is really painful. Yep. So they may not be eligible for the test, but if you speak to VCS, they can often help you work out what your options are, and it might be that you'll pay for that test. So all these things are great, but people have to know about them. If we don't get the word out there, then we don't get people in. A practitioner's word is a very strong motivation for people to screen or to be vaccinated. But we've got websites now, and there are many, many things out there on the web that you can actually use to increase knowledge about screening in your service. And I saw one the other day, it was Pink Hope, where you buy pink lipsticks, and you all put your pink lipstick on, take a photo, put it on Facebook, hashtag Pink Hope, I think it was. And I just think, how fantastic would that be if everyone in the surgery got the pink lipstick on, and what would that tell your patients who had perhaps had cancer or had family with cancer about the surgery and your interest in them, and wouldn't they feel more cared about if they could see something like that happening? And there's many others. The Bowel Cancer Australia, I think June is Bowel Screen Month. You can get banners for your emails. You can get Facebook things to post. There's lots of things. And I even saw one surgery who really had gone over and above, and they were wearing a poo suit, which you can actually get on eBay for $25, because I did check it out. And they were taking it in turns to wear this just to increase the knowledge that bowel screening, which is the one which surprises me. Only about 40% of people do, and yet such a high incidence of bowel cancer.
I think you've highlighted very well the role that nurses in primary health care can play, particularly in screening and prevention of cancers. And I think generally they do a good job at that, and that's one of the things they do well, but there's always room for improvement. And thank you for talking us through some of that process. I think, Meg, when you were talking, you also identified that once people are diagnosed and they go off into that chasm of treatment, we really don't know what happens as primary healthcare nurses. So I was wondering, Jess, if you could just talk us through what that looks like, because I know, having worked in primary healthcare for 20 years, I have really very little understanding. I've had no family members. So could you just talk us through that journey for people?
I'll shed some light on what happens when these patients disappear. So the treatment journey starts with diagnosis, which will most likely happen in a GP's office but may happen elsewhere. In Victoria, we triage our patients based on their tumour type and any complicating factors. So a category 1 patient might be someone with an acute leukemia or an aggressive lymphoma or a solid tumour. When I say solid tumour cancers, I'm referring to things like lung cancer, bowel cancer, any cancer that develops into a solid mass, versus hematological malignancies like lymphoma, leukemia, are cancers of the blood system, so they don't form solid tumours. But these patients can have additional complications, which may mean they need to start treatment earlier. So a Category 1 patient would need to see a specialist, whether that's an oncologist or haematologist, within 48 hours and start treatment relatively rapidly. Whereas someone in a Category 2 or 3 may not need to see a specialist until within a 2-week period and start treatment within a time frame that's set out by their tumour. And this is something that you would be able to find in the optimal care pathways, which are a really great resource. I know a number of us will talk about those. And they give a great overview of the treatment trajectory for every different tumour type. Some of the types of treatment, I thought I'd just give an overview of the types of treatment available to patients. Yep. So surgery is one option for solid tumour cancers. Some cancers can be resected, some cannot, and that depends on whether they've metastasised, how locally invasive they are. So if they can be removed, they will be. A good example of that might be pancreatic cancer. If it can be resected, it's got a moderate survival rate. Unresectable pancreatic cancer still remains one of the worst cancers in terms of 5-year survival. So surgery is an option. Many cancers will have a multitude of treatment options. So something like breast cancer, Meg would probably know, you would go through surgery, chemotherapy as well as radiotherapy. So chemotherapy is another option. That's where we use cytotoxic drugs we will give those usually intravenously, but there are other ways to administer them. And they work on the DNA of the cell and interfere with cellular division, so they stop cancer from dividing. But as we may know, chemotherapy comes with a lot of unfortunate side effects. So it targets rapidly dividing cancer cells, but it also targets our rapidly dividing healthy cells like hair, skin, and our mucous membrane. So that's where a lot of the common side effects we see come into play. Yeah. Surgery, radiotherapy is another treatment option that uses high-dose X-rays to damage the cell's DNA and stop cell division as well. And more we're seeing immunotherapy come into play. So immunotherapy works by tagging the malignant cells with a marker and initiating the body's own immune system to destroy those cells. So if you want more information around that, and I think it can be handy working in primary care to have an understanding of what types of treatments are available to patients. I've listed EviQ as one of the resources that you can look at. EviQ is a platform for all cancer treatment, so all the protocols we use for treating every kind of cancer are available there, and it gives you a great overview of the drugs involved, what side effects to expect, and an overview of the treatment process. So how that might look in the acute phase, a patient would be diagnosed, they'd see a specialist, and for most patients they would come in for chemotherapy if that's part of their regime. They may come into a chemotherapy day unit. If they're more unwell, or they might be one of those Category 1 acute patients, they would be admitted and start their treatment journey as an inpatient, which is why you may not see them for quite a long period of time. If you're admitted as an inpatient, and particularly if you have complications, it can result in quite a long stay. But for patients coming in for chemo, they may come in once a week, once every 3 weeks, once a month, and that would start with seeing a cancer nurse, or they'd see their oncologist, and they'd see a cancer nurse for education around their treatment. We would look at inserting whether they just need a drip or whether they might need a central line, like a PICC line, during that treatment. So during that phase, like we've mentioned, they'll most likely be followed up by their oncologist or haematologist or nurses, and they'll stay within the tertiary sector, I suppose. But we do often tell our patients when they're discharged that if they've got symptoms they're concerned about, to follow up with their GP. So I think as primary nurses it's good to have an understanding of the common signs and symptoms that may come into play during that time.
So that sort of leads on to our next question, actually, Jess, which is what are some of the common, and this is for everyone really, what are some of the common issues related to cancer that primary healthcare nurses may encounter or could help with? So maybe, Meg, from your perspective, would there be anything there?
No, you're right. just a bit croaky now. Certainly, there are issues with, depending on what treatment you're having. If you're having chemo, you'll have issues with nausea, you'll have issues with hair loss, with fatigue. If you're having radiotherapy, you'll have issues with burnt skin, pain management. If you're having hormonal therapy after breast care treatment, you may have issues with joint pain. My fingernails were damaged, my sweat glands were damaged. Any number of things that you might need help with, and primary health care can certainly be of assistance to you in those areas.
So really upskilling in the pathways that you've talked about,
Absolutely.
Jess, and just being aware of what those potentials are. Do you want to talk a little bit more to that sort of?
Yeah. I guess some of the common side effects, as Megs mentioned, are things like nausea, vomiting, diarrhea, fatigue is a really big one too. Loss of appetite. These are all things that you might encounter. So I guess where it comes into play for primary health nurses is about knowing where you need to draw the line between when do I send this patient into hospital, or can this be managed in the community? Because for cancer patients, I suppose that threshold is just a little bit lower. For some of the more acute side effects and symptoms that hopefully you might not see in primary care, hopefully they're going straight to emergency, but chemotherapy can have an effect on the bone marrow cells, and our bone marrow cells make red blood cells, white blood cells and platelets. And when our white blood cells decrease in their cell counts, patients can be at risk of developing what we call febrile neutropenia. So where you and I may catch a common cold, our immune system will mount a response. When a patient is neutropenic, they just don't have that ability to fight back infection. So we'll often tell patients to present to their GP if they've taken their temperature and it's above 38 degrees. Or they're feeling unwell with any other symptoms. So if someone like that presented to a GP clinic, that is an example of a time where the patient would need to go straight to ED. But understanding how to manage all of the other side effects and when they need emergency treatment versus when they need community treatment is beneficial in knowing. And I think that's where EviQ can come in again.
Yeah.
They have a whole website dedicated to EviQ education. And they have information for patients and for nurses around how to manage those side effects, how to manage them in the community, and when to make that call to send them into hospital.
Yeah. Anyone else want to add anything to this?
As a women's health nurse, I mean, one of the things that I saw a lot of, but this is more of a late effect after treatment, was problems with vaginal dryness and not being able to use estrogen cream. But there is a cream, it's called Replens, which is a vaginal moisturiser and is very good, but it's actually very expensive. So you can get samples. I used to be able to get samples sometimes and give those to people. You can get one free one from the website, so that's not going to last very long because you need it to use it 3 times a week. But you can usually titrate it after use to maybe just usually once at the weekend.
Yeah.
But it's useful to have that knowledge to pass on.
I believe and understand the role of the primary care nurse in being able to support people to self-manage.
Yes.
And that is vital, because often people may have they're not able to assume the role they would normally do because they're overwhelmed with anxiety, so their abilities decrease in a temporary basis, but they need that confidence and support through primary care to actually assume what they would normally be assuming, to take those medications as prescribed, to report things when they should be reporting them, to not wait till they've got an appointment, to report things in a timely manner. So I think that's
And
a
I guess
vital role.
from my experience as well, people who are going through treatment often do disappear. So nurses in primary healthcare kind of have the perspective it's not my issue, and the patients don't come in because they don't see it as a general practice role to actually have a place there. So how would you respond to that? What should nurses be doing in primary healthcare to make sure that isn't the case?
I might
just pick up on something that Meg, you mentioned earlier, and I'll pick up again later, but and speaking to self-management, that idea of supportive care screening that we talk about, and I'm with Cancer Council in Victoria, and there's a Cancer Council in each state and territory around Australia, and one of the biggest focuses for us in my particular area of the Cancer Council is that provision of supportive care. So all the things that happen in and around every other section of the trajectory that has been spoken about today. And there is that sense that it's someone else's job, whether it's primary care thinking that, or clinical care thinking that, or supportive care services thinking it's somehow other people's jobs as well. I think that idea that primary care often, and I know from our perspective, and again I'll pick up later, one of the biggest referrals we make back when people are calling our information and support line at any point in a trajectory, whether they have a diagnosis, whether they don't, whether they're at the end of their treatment, whatever stage they're at, one of the biggest constant referrals we will speak to someone about is, have you spoken to your GP or a primary care nurse about this? And they often will not think or pick up that that is a resource that they can use. Some have a fantastic relationship with their primary healthcare team, and we encourage that and maximise that, but some just have not connected the dots. And that's really where Cancer Council services and other NGOs, other community-based services will really try and connect those dots for people between the different sectors that they're going through. And it's really, and I know Nicole will pick up on this as well, the number of people that are living longer with their cancer or beyond their cancer because of the new treatments that Jess may have mentioned is only going to increase. So the idea that people will be living longer with whatever effects of cancer, mental, physical, emotional, practical, is going to continue increasing. So the role of primary care nurses is only going to increase in importance. And I'm happy to pick on that a bit later too.
And I guess then it's as we see it as a team approach to care that we can enhance what happens for those people in that journey.
Absolutely, we're a team,
And communicating that across sectors.
Yes,
So
absolutely.
primary care nurses are saying, I play a role, and we are saying, you play a role.
Yes.
And go to your GP, have that relationship.
Yeah, and include them in the journey as well, rather than the disconnect that we have.
Yes.
That's so true.
And making sure that patients are aware of that ability to tap back in at various stages. I think that's important too.
I think if we could empower patients perhaps to ask to speak to the primary care nurse. Because often that maybe, the receptionist may not think to put you through to the primary care nurse, may just think, oh, the doctor. So there needs to be some work in actually nurses putting themselves forward as having an interest in this area.
And seeing as it a team approach,
I
think is really the key, and that's part of it, isn't it?
Yeah, well, that's part of the receptionist, a part of your team as well.
Yeah. So then if we move on to you, Catherine, and think about what the Cancer Council services and resources are that are available to nurses, can you just talk us through that a bit, just to increase our scope of knowledge around what's available?
Yeah, absolutely. And for primary care healthcare nurses that are out there and may not be aware of the services and supports, you're not alone. I think one of our biggest challenges is helping people to understand who we are and what we can provide. In terms of the way in which cancer councils can be utilised and the services that we offer, as I say, our information and support line, it's a national number that's available, 13 11 20. Meg mentioned that, so thank you for that. When you ring that phone number, you're going to be speaking to a qualified oncology professional who can answer questions and provide support at any stage in the cancer experience, whether you are not yet diagnosed and have questions about screening or detection, family history and risk, through to just having received a diagnosis and waiting to start treatment, not understanding what may happen next, right the way through to when you're in active treatment, when you have finished active treatment, whether you have a cancer that can't be cured or whether you're now living with a cancer that has been cured. So to understand that trajectory, Cancer Council can be accessed at any point in that process, and that's what we encourage. And as I say, the nurses really act as navigators and connecting of that dots. We really aim to help people understand the system, the trajectory that people will go through, and Jess mentioned before resources like the Optimal Care Pathways. These are a nationally available resource, and there are clinician versions available. This is the What to Expect guide, which is a patient-facing resource of the same, and these exist for tumour streams to understand the pathway from start to whatever a finish may look like. And the first 2 steps, especially for primary care, we have done multiple research projects and academic detailing sessions with GPs across Victoria, and I know similar projects happen around the country, to help people understand what these pathways are and what the first 2 steps in the pathway are concerned with are around screening, early detection, and how that works, and then what happens once something may have been picked up. And helping primary care to understand what their role in specific cancer types are. I think we've talked about cervical cancer and bowel cancer and breast cancer, which are the main cancers that have screening available. But we know that it can be incredibly hard to detect, prevent or minimise risk for other types of cancer. So primary care have a huge role to play in that and understanding what that space looks like. But as I say, for the nurses on 13, 11, 20, understanding how primary care can assist with those supportive care elements. We've talked a lot about treatment and side effects, but not a lot about the emotional impacts of a diagnosis, the practical impacts of a diagnosis, and that's where Cancer Council services specifically can really step in and complement the care that's happening in clinical settings. Not every cancer setting will have a designated social worker or designated psycho-oncology, which is around psychological counselling or support for emotional issues. Financial issues are honestly one of the biggest growing inquiries that we get. 40% of the connections through our service are relating to financial, legal or practical issues in a service, because they are often the things that get missed in the clinical space. And that's often where people will say, I don't think that's my role, or it's not my role to ask. But if you think about your connection with people diagnosed with cancer, we all have a role to play at the different touch points in checking how supportive care elements are going, however you want to describe that to people, because these are the things that will stop people reporting their side effects, uptaking treatment, complying with treatment and their side effects, because potentially they may not even be able to afford it. They haven't been told up front about the costs. I could go on for ages about that element to it, but I think that is something that if you are speaking to people who are not sure about what happens next, not sure about services that are available to them, they have questions and want to speak to someone who's been through cancer before, who can speak to them about a lived experience while they're making decisions about what treatments to have. I really encourage everyone to have a look at your local Cancer Council website, become familiar with the services that are available, things like wigs, transport, accommodation, our holiday break program and assistance with other things. Financial and practical assistance is something that cancer councils can help with directly. We work very closely with social workers and other NGOs to make sure that people access all services that are available to them in complement to their clinical care. So that is a resource that can be utilised at any point, and if we don't have a service or we don't have an answer ourselves, we will help navigate you to those that do. We'll help you clarify questions. It really is a very robust service that is at the moment quite underutilised. So you don't have to know everything about cancer. Primary healthcare needs to know everything about everything, it seems, and my hat is off to people working in primary healthcare for the sheer range of inquiries you get. I know the range of inquiries we get just related to cancer. I cannot imagine what that is like, working across all illnesses and situations. But for that very reason, you don't have to be a specialist in cancer care, but knowing about what is available to support you is how we can assist. So you have someone who mentions an issue about cancer, they're waiting for treatment, they're being treated outside a clinical setting, they're not sure what happens next. You yourself as a health professional could call Cancer Council and ask, what can I do for my patient? Or at the very least give them a brochure and a resource about what they could do. But as you mentioned, GP or practice nurse referral, any clinical referral to our service will absolutely increase the likelihood that someone will follow through if someone in their healthcare team encourages them to do that and helps them understand why they should do that. So yeah, I hope that helps people to understand you don't need to remember everything that's being discussed today. But
so
know
I
what
think
services are
what you've said is fantastic and it's really good information. I guess nurses are really good at being across a lot of things, but not knowing the ins and outs of everything really well sometimes. So if a nurse wanted to refer a patient, what process would that look like?
it's as easy as either pointing them directly to a website where you can put referrals through to the 13, 11, 20 team and know that they'll be actioned in a time and a way that is suitable to the person, whether it's via phone or via email. The person themselves is welcome to call. It's not a crisis management service, so generally cancer councils will have business hours, but if you leave a message, you'll be followed up the next business day. Emails are followed up on the day that they're sent or the next business day, and there is message on all answering machines about critical care elements as well. So it's as simple as knowing the number. If you remember nothing else from my particular presentation, 13, 11, 20 is what I would encourage, because everything I've mentioned and even touched on will be available through our websites. And know that if you are referring through to Cancer Council, you will be, people referred into that service will be connected or encouraged to connect back with primary care, with their acute care team, with any other service or NGO or community program that may be able to help with any of the other non-clinical issues that may come up. So that idea of that real supportive care screening. So it really is quite simple to refer.
Yeah, and just to clarify, it doesn't need to be through a GP. It can
No,
be through the
absolutely
nurse.
not. Through anybody, and anyone can self-refer
Yep.
as well. So as we say, people, it makes sense that if someone's not had a cancer experience in the past, why would they know what's available to them? They've never had to know. So for people who are the people that are breaking this news or delivering this news to people and then supporting people, it is our role to know what is available and how we can direct each other and support each other. It comes back to that team approach. So yeah, primary healthcare, knowing what is available and how we can support, and our role in each step in the process. We aim to make your lives easier and to take some of the burden off what you are expected to do. So I hope that helps people understanding and gives a bit of an idea about where you can go to look for support. So starting with your local Cancer Council website is kind of then the gateway into all other services.
Can I just ask about people who don't speak English? How would you arrange?
So we access the Translating Interpreting service, which is a national service, and that's free. So there's information on each Cancer Council website about how to do that, and it's in different languages as well. So it's a separate phone number that people use. I think it's 13 14 50 off the top of my head, and they will be connected to the same Cancer Council 13 11 20 team, and we'll have that conversation with the aid of an interpreter, and that's how that happens. Yeah, and all of the these style resources that I mentioned earlier are translated into the top languages that we have in the country. So where we can, we aim to make them as accessible as possible. So having a look on your local Cancer Council website and seeing what resources are available in other languages, and they're growing all the time, is a great place to start.
Yeah, that's a really good point.
Yeah, thank you for that.
Great. So now, just to let you know, for participants looking in on this webinar, we have a poll that will now be appearing on your screen. If you'd like to take a moment just to select the answer that most suited to you. And the question is, cancer survivorship is an essential part of my nursing practice. And if you could just take a moment to just think about that and give us a poll, and we'll be able to get back to you with some sort of answer. We'll leave that open for about a minute or so. So yes, it's been really interesting, hasn't it? Just kind of focusing on that, yeah. We'll close that poll in about a minute, is that right? Yeah, thank you, sorry. We might move on now to Nicole. And Nicole, thinking about survivorship, and I think in primary health care, that has been an area that we haven't had a lot to do with, and yet it's such a strategic area when people post-treatment have so many fears and just things that they need to deal with. The primary healthcare setting is something that could really be active in that place. Can you just talk us through cancer survivorship and some of the role that the primary healthcare setting could play?
Well, first of all, I'd like to acknowledge the fabulous role that primary healthcare nurses already do play in providing cancer survivorship care and providing optimal cancer care. You are already seeing people with chronic diseases and helping them manage these diseases. You have relationships with these people prior to their cancer diagnosis, and it's that ongoing relationship that is very, very important. We're seeing a huge rise in cancer survivors, and more people are going to have their follow-up in a shared care arrangement with their GP and their treating oncologist. So more people after a cancer experience will actually be receiving their care from the primary healthcare nurse and the GP. So that's an important thing to remember. But also not underestimating the impact of the role that you already have. The other thing I want to just clarify before we move on to a bit more about survivorship and survivorship issues is really what the term means.
Yeah.
Because it's not exclusive to that time after cancer. And it's important to also recognise what that term means to the person themselves. You know, a cancer survivor is classified from time of diagnosis, so they can be living with or after cancer. Not unfortunately, but traditionally, cancer survivorship care has been provided at that time after a primary treatment. So it isn't actually an accurate term for the care that is provided, because we've got changes now, as people have been talking about, with better treatments, ongoing therapy. So people are living longer with the cancer diagnosis. They're living longer on treatment. People who have no current evidence of disease after active treatment go on to maintenance therapies in long-term capacities. And all of these people are survivors, and all of survivorship care is relevant to them. So just to clear that.
Yeah.
The other thing is that when we consider survivorship care, there are some common survivorship issues across many cancer tumour streams. So people may have had a different treatment or have a different diagnosis, but there are some common issues across all of that. So it's important to consider those, and also consider the way people respond or react to their diagnosis or to finishing a treatment episode, because they can be completely different. On that point, Australian Cancer Survivorship Centre has developed a common cancer survivorship issues directory that's in the resources. So in that introduction where you were indicating where to access those, if people go to that website, they'll be able to look at evidence-based information, tools and supports that people can use in primary practice to help patients at any time point throughout their cancer trajectory. When we're looking at the common issues, some of them have been mentioned. Fear of cancer recurrence, so we've got psychological issues. Fear of cancer recurrence or disease progression is one of the top unmet needs for cancer survivors in Australia. And often the fear can be disproportionate to the actual risk. So irrespective of having a low-risk cancer and it appears everything's great, people can still be completely worried and immobilised by this. Depression and anxiety are common. So people at times may need some professional support to deal with these strong emotions. And this is where we see the mental health care plan coming into play. So people can actually access community-based supports that are relevant to their needs. Looking at other common issues, we've got things like cancer fatigue that was mentioned. And cancer fatigue is one of those things that is often underreported, so it goes unrecognised, but it has a huge impact. There can be unresolved pain or pain that develops after treatment. There could be sleep issues related to worry or pain. There could be what is called now cancer-induced cognitive impairment, or chemo or cancer fog, big name. Yeah. But what it means is that there are it impacts memory and concentration and ongoing effects for things like getting back to your normal life, resuming your normal role, having that high-powered job, reading a book, as simple as that. All of these things can be impacted. Then we move on to other things like fertility issues, and you can look at sexual and intimacy issues that have huge impacts within relationships, or for people who want to start a relationship. Then for women, there could be treatment-induced menopause, so lots of physical complications and consequences as a result of cancer treatment also. Practical issues we touched on, such as financial toxicity, another new term, that is it's really talking about the out-of-pocket costs associated with attending a hospital for treatment, for cancer-related after-treatment drugs, for getting transport to a hospital, even paying for parking. These types of things have a real impact. And then we're looking at the loss of income associated with return to work issues, or getting a job, or even returning to study, or trying to actually take up study, especially if you've got memory or concentration issues. So there's lots of real problems that people may actually experience a bit further down the track, or they may be evident when they finish treatment.
So Nicole, do you see sometimes nurses are very good at initiating conversations, so that could be a role that a nurse in primary healthcare could play, just initiating those conversations, being aware of what those trigger points are or potential points are, and just initiating that kind of conversation?
Absolutely. And they can be sort of the top 5 things you ask about when you see someone. Or often we approach it in a way that we have a couple of things we want to ask you. Is there anything that you want to ask? Because you've probably experienced this, that conversation that happens just as someone's leaving the door.
Call it the doorknob conversation.
And that could be the most important issue, but it's not going to be addressed till the end. I think Catherine was saying that people don't think that they can bring things up.
So for primary healthcare nurses, just being aware of those potential conversations and making that conversation.
I was just going to say, I think sometimes with any conversation, and I know around supportive care in the clinical setting, a lot of times I hear from, whether it's primary healthcare or clinical nurses, that if they aren't clear on what a referral pathway might look like, there's a nervousness to ask the question and open that box if they're not sure what to do with the answer. And I completely understand that it depends where you're working, what setting you're at, your awareness of services, but that's where knowing who the key people are, whether it might be a social worker, whether it might be a nurse coordinator, whether it might be a supportive care service, having those sort of in your toolbox so that you know you don't need to fix everything, and you can't. None of us can. We work in the team that we talked about, but sometimes there's that nervousness to ask because you don't know what to do next when something gets mentioned.
And what we're doing now is actually providing people with survivorship care plans. Australian Cancer Survivorship Centre has the mycareplan.org, and it's a platform where health professionals and survivors can actually develop a plan. It's to prepare people for what to expect. It provides them with some information. It's also a communication tool for other health professionals involved in care. What it comprises is a detailed treatment history, information about signs and symptoms to watch out for and report, how to manage common side effects, a treatment follow-up plan, and also a well-being plan. And we see primary care being able to use these types of plans to develop a chronic disease management plan. So we recommend
that was my next question. Do you see that role? Because as a nurse working in primary health care, you know, our criterion for care planning is, you know, if they have a chronic condition or a terminal condition. So for survivors, they kind of vaguely fit that category. Can you just talk to that? You know, is there a place for care planning other than mental health care planning for survivor patients in primary health care?
Well, we believe, you know, cancer has a classification as a chronic disease, and certainly a chronic disease management plan is very suitable for someone. And what we're advocating is that people could use the information, you know, after treatment care plan or survivorship care plan to actually support the development of a chronic disease management plan based on your assessment. We detail information that may be what the person is experiencing right now, but also things that they may experience in the future, and Meg has eloquently told us about later and long-term effects of treatment, so it's watching out for those things. It's also using the well-being plan as an ability to shift this focus from illness to wellness, and reinforcing these modifiable lifestyle behaviours. So people are going to take up exercise, quit smoking, have a healthy weight for height, or reducing the risk of some cancer recurrences, but also reducing the risk of development of other cancers, taking up screening, these types of things. And you do that so well as a primary healthcare nurse, and you have the opportunity to have more of a long-term ongoing relationship to reinforce these messages and these positive messages.
We're just getting close to the end of time and we've got some questions, so we might try and get through a couple of questions, and those that we don't get answered, we will certainly try and get answers to you off air. So Sheena asks, any advice on managing patients whose risky and known harmful alternative therapy, e.g. black slave for skin cancer? Someone want to jump in there?
I was just going to come from I guess the questions that we get in that regard, and for us in an information and support perspective, we hear about these things a lot. It has not minimised over time. If anything, it is getting more with the rise in social media and the idea that a lot of the time in younger demographics or in areas where you totally understand people are looking for something that's going to give them hope and going to give them, you know, something to hang on to. So from our perspective, it's about understanding why are you asking the question, what do you know about it, where have you found your information, what potentially might be you're not finding out about or you're not aware of that's making you look at these alternative therapies. And really for us, it comes back to an education point of view and making sure people understand risks, side effects, treatment interactions, evidence behind a treatment and potential risks involved. And at the very bottom for us, we can't tell someone what to do. All we can do is give them the right information and a referral pathway to have a more open conversation about that, and do our best to illustrate the pros and cons. And in some instances, like a black salve, there are huge risks potentially with using that treatment. So it's not about saying, no, don't do it. It's about making sure you understand an informed decision, absolutely, from that perspective.
Another question, sorry, can I go on? Repeat the top 5 things to ask. The question. So
the top 5 things to ask someone in regards to how they are travelling after a treatment or during treatment. I would be asking how they're managing emotionally. Do they have any cancer worry or concern? So actually coming out with the question and being sort of naming the elephant in the room. How are they managing their symptoms? And if they're not being managed or they're reporting them not being managed, asking how they're going about that. So perhaps it's really supporting someone to be able to self-manage. Perhaps they're not understanding the information that they have been given. Do they want any more information or support? And would they like referrals? Are they to help them achieve what they would like to achieve, what could we do? Or what could we put in place? And sometimes if we're time poor, often it's just to ask the top thing that you can deal with in that encounter.
Can I add one more to that, and that is to actually ask them what else is going on in your life. Because cancer is not the only thing that's happening. They may have issues with looking after kids or running their business or having somebody look after their pets or whatever it is. There's a whole life going on out there, and asking them what else is happening may also lead you to be able to help them with referrals to other people.
Absolutely.
Very valid point. Great. Thank you. I have another question. If an immunosuppressed and unwell patient comes into your practice, how should that be managed? And I think you touched on that too.
So I guess it depends. Was the question if the patient is also unwell?
If an immunosuppressed and unwell patient comes into the practice.
If they're immunosuppressed and they're unwell, and by unwell we mean a temperature of 38 or above, and really any other symptoms, if they've got any vomiting, diarrhoea, even if they just feel unwell, straight to ED. What they need is bug cultures and antibiotics immediately, because these patients can go downhill in hours.
And not great having them sitting in a waiting room for a period. So if you're able to get them unwell people, if you're able to get them in a more confined space, is always helpful.
Thank you, great point.
We're running short of time, so I'm going to have to cut it there. For those people that have asked questions that we haven't answered, we will get back to you with those answers. I want to thank each of you for coming today. Thank you, Meg, for your story and sharing with us. For Nicole, Jess, Catherine, and Jess, sorry. Thank you so much for sharing your time with us. A poll will come up now, and if you could take time just to fill in that evaluation, that would be very helpful to us as an organisation presenting webinars, but also to see the effectiveness that this has been in informing you around cancer care. Thank you so much for your time.